This is Breakthroughs, a podcast from Northwestern University Feinberg School of Medicine. I'm Erin Spain, Communications Director at Feinberg. Black men are more likely to get prostate cancer and more than twice as likely to die from the disease than other men. Dr. Edward Schaeffer has developed a research team to better understand this problem. He joins me today to talk about his latest discoveries, which are paving the way to precision medicine for aggressive prostate cancer. Dr. Schaeffer is the chair of the Department of Urology at Northwestern and a Northwestern Medicine urologist with a specialized practice in prostate cancer. Thank you so much for coming on the show.
Oh, thank you very much for having me.
Describe to me the state of prostate cancer today. How far have we come in the past 20 years in treating this disease?
Yeah, prostate cancer has come a long way in the last 20 years with substantial gains in how we diagnose, treat, and manage men with prostate cancer. And that has that evolution and revolution in how we do this is a multifaceted approach. It has involved input from many clinicians who focus on better diagnosis, clinicians who focus on better treatment of localized disease, as well as clinicians who focus on men who have more advanced prostate cancer. The number of new prostate cancer cases in the U.S. is around 190,000 new diagnoses every year, and there's around 33,000 deaths from prostate cancer annually. Now, that number of new diagnoses has overall declined due to refinements in how we test for and screen for prostate cancer over the last 10 years. The number of deaths from prostate cancer has gone down over the last decade as well and is now kind of in a plateau phase. So we had substantial gains in enhancing the survival for men with advanced prostate cancer that were made over the last 10 years with a record number of FDA approval of new compounds to help treat and control the disease. And we've made substantial gains. I think we have a new challenge on our hand, which is to reduce the number of deaths from prostate cancer down below 30,000 and continue that decline that we had experienced very nicely over the last 20 years.
You mentioned that there's been new treatments, new therapies available. What is the typical course of treatment these days?
So the course of treatment is quite varied. So most men who are diagnosed with prostate cancer, upwards of 93 to 95% of men who have a new diagnosis of prostate cancer have localized prostate cancer. And those individuals have a wide array of options about how they can manage their prostate cancer. So there's been an evolution in how we think about this localized prostate cancer space, so to speak. And these days, we are definitely monitoring minimally aggressive prostate tumors much more aggressively than we have in decades past. And this has enabled men to live out their normal, healthy life without having to undergo what can be life-changing interventions such as surgery and radiation. Now, in addition to having better, more refined, augmented surveillance for men who have low aggressive, low volume prostate cancer that's localized, we have also made substantial gains in how we manage and treat men who have the flip side, that is much more aggressive localized prostate cancer, as well as men who have prostate cancer that is more advanced, that may be spread throughout their pelvis where the prostate lives or throughout their whole body. And advances that have occurred in the more, quote, advanced prostate cancer space when prostate cancer is metastatic are equally substantial. And this has been a tremendous benefit for all of our patients who we really fight for every day. There has been a record number of FDA approvals of new advanced medications that can fight prostate cancer that go at the vulnerabilities of prostate cancer. This includes FDA approval for immunotherapy for men with prostate cancer that's advanced, as well as advanced hormonal medications that can really try to address and cripple prostate cancers at some of their basic foundations. So the landscape for men with prostate cancer has changed substantially, and it's changed substantially for the better, which is really a good thing for all of our patients out there.
The topic of this show is Black men and prostate cancer. Race is a known risk factor for prostate cancer. Can you tell me about that and other known risk factors for prostate cancer?
Yeah, it's a very good question. So the statistics for prostate cancer are that around 1 in 8 or 1 in 9 white men are diagnosed with prostate cancer in their lifetime. That number is much higher for black men. It is on the order of around 1 in 6. So there's around a 1.8-fold increased risk of being diagnosed with prostate cancer if you're a black gentleman versus a white gentleman. And there are also higher chances that once one is diagnosed with prostate cancer that they would die from prostate cancer if you indicate that you're black versus white. So there is a disparity in terms of the number of newly diagnosed cases between white and black men, and also there's a greater disparity between the number of men who die from prostate cancer if you're white or black. And this is an important observation that's been made and been established over many, many decades. And it's something that was of very much interest to me when I became involved in this field and this profession about 15 years ago. Now, in addition to race and ancestry as a risk factor for prostate cancer. And when I say race, we imply what the patient reports that their race may be. And ancestry can be where their origins are from. So men of West African ancestry, men of Afro-Caribbean ancestry, and men of Ashkenazi Jewish ancestry all have increased risk for developing prostate cancer and generally have increased risk for developing more aggressive prostate cancer. Other risk factors are family histories of prostate cancer in first-degree relatives. So men who have a brother or a father or an uncle who have had prostate cancer, they have higher risks for developing prostate cancer. And also individuals who have family histories of other cancers. So the key ones that we focus in on are those that have family histories of breast, ovarian, and pancreatic cancer. And those 4 cancers, prostate, breast, ovarian, and pancreatic cancer, all can be found in individuals who have specific mutations in a couple of select genes. So we ask about that. We used to be very focused in our space, in our community, asking about family history of prostate cancer alone. We thought that it was kind of off by itself. But what we've learned over the last decade or two is that you really need to ask patients about their entire family history. And that includes all cancers, not just prostate and not just breast, ovarian, and pancreatic, but all cancers, because there may be links that we previously didn't recognize that are important in understanding each individual patient's disease risk.
So you take these family histories and there's screening that takes place as well. Where do we stand today with screening for prostate cancer? I know there's been some controversy in the past about the prostate-specific antigen PSA testing.
Yeah, prostate cancer is screened for with 2 tools. The first tool is a blood test, and that's called the prostate-specific antigen blood test. That is a test that is done during a regular routine blood draw that you would get from your internist while they're checking maybe your cholesterol, for example. And the other way that we screen for prostate cancer is with a rectal exam. So that is because you can feel the prostate if you do a rectal exam. And about 10 to 15% of prostate cancers in the U.S. are picked up because there's an abnormality on someone's exam when their blood work may be, quote unquote, normal. Now, in general, the controversy regarding screening for prostate cancer stems from the use of the PSA blood test. And there's a long history about how to use the PSA blood test. But for the purposes of our podcast today, I would say that the way that we as urologists would advocate for use of the PSA blood test is in a shared decision-making process. So whenever patients will ask me for advice about what they should do, we have a discussion about their risk. And we try to put several components of their individual life history together to determine whether or not screening for prostate cancer makes sense. So what are the risks? Well, we talked about a couple already. One is their race, one is their ancestry. Others include their overall health. Have they had other significant health issues that may potentially shorten their life expectancy? And those would be things like major heart attacks, a stroke, those kinds of issues, other cancers. And so you put their whole family history together and you try to assemble, well, what do we project this individual's life expectancy to be? What do we know from taking a good history on the patient about their own family's history of having prior cancers? and put that together, and then also ask the patient how they feel about getting these tests and what are the pros of doing the testing and what are the pros of early detection and what are the potential cons, what are the downsides for testing and what may be the downsides for early detection. And after a thorough discussion, which can last 45 minutes in some cases, only then do we make a decision about whether or not we should proceed forward with the screening.
In the kind of thorough discussion that you're describing, I am curious, do you think COVID-19 has impacted your ability to have these kind of screenings and discussions with patients?
I think that the discussion process has not really been impacted by COVID-19. I think that particularly at Northwestern Medicine, where we were very proactive about rapidly reaching out to our patients, not through direct face-to-face interactions, but through video-based and telephone-based interactions, that we were able to really mitigate a lot of those potential issues. But I do think that so you're able to have those discussions and have a thorough discussion about that with patients. And it's interesting, in fact, in some ways the discussion can be better because some people are nervous to see their doctor, and some people may feel that they're more comfortable making their own personal health decisions from the comfort of their own home. We always advocate, though, that patients for new visits do come see the physician because, as I indicated, part of the screening process that there is not controversial at all is doing the rectal exam. And so we strongly advocate for that. And for all of our new patients that we see, we really like to, if we can, see them in person and actually do a physical exam because that is important. I would say, no, there's not been a major impact. It's changed how we do medicine, but I don't think that it thus far has had a negative impact. Now, I do know that there are patients that have developed somewhat of a fatigue about seeing doctors or thinking about health because COVID has really been at the forefront of a lot of what's happened in the world for the last year. And so they're fatigued about talking about or thinking about their own health. And so for those individuals listening today, I certainly would encourage them to not abandon their doctor. And there are other mechanisms to interface with their doctor besides going out to the doctor's office. And so if they're concerned or scared or have a little fatigue, just remember that we are their advocates. We want them to have healthy, full, thorough lives. So that's kind of how we view it. We want to reach these people so that we can help them make decisions about their own personal health.
That is a very good reminder because, COVID-19 fatigue is real. Thank you for all this background here to kind of set up where we are today with prostate cancer and what treatments are available. But I want to go back to what you said about 15 years ago. You first zeroed in on this health disparity for Black men with more aggressive prostate cancer. Tell me about that and tell me about your approach to better understanding this problem.
Thank you for asking that question. And I'm going to just expand on that a little bit because I'm very passionate about this. I'm a clinician. I'm a clinician scientist. And so I try to learn from my patients. I always find that my patients are my partners in discovery. And I always aim to deliver the best care to all my patients. And so I learn from them all. I learn sometimes that I've done a great job for them, and sometimes I learn that I could have done a better job. I've always done that, and so I have very distinct memories about, I always focus on individual patients, and is there something that I could have done to improve their outcome, either at the time of their diagnosis of cancer or in their treatment and their management of their cancer. Yes, the American Cancer Society publishes data on cancer outcomes, and it has for many decades highlighted this outcome disparity between men who are Black and men who are white in terms of their probability of being diagnosed with prostate cancer and, more significantly, dying from prostate cancer. But that data that you can read about on paper is important, but when you begin to experience it in real life, it becomes much more impactful. And that impact for me was a driver to really adjust my whole research program to try to understand, what are the drivers on a molecular level? What are the drivers of aggressive lethal prostate cancer in all men? And also, which men are at greatest risk for developing this aggressive lethal prostate cancer? And under those two quote unquote umbrellas, I began to develop a program to try to understand better, are there molecular differences in prostate cancers amongst men of African ancestry, amongst men who report themselves as Black versus white, and to try to refine that understanding so that we could potentially improve outcomes for all men with prostate cancer.
Well, and in recent years, you have discovered that there are biologic differences in prostate cancers, specifically in Black men. Tell me about those discoveries.
I think that there are two major overarching themes that scientists focus on when thinking about differences in terms of cancer outcomes between men who report themselves as white versus Black, or men who have African ancestry, West African ancestry in particular. And some of those factors have to do with access to care and their ability to achieve appropriate care and so forth. And that is a major issue. Those are kind of social determinants of the outcome. And those always have been and remain important, and I'm a major advocate for those. Similarly, the understanding of the potential differences in the diseases between different ancestries is something that was not well described. So we've had several major initiatives to try to understand that better. We have made observations that there are specific genes that are mutated or altered in men of African ancestry that are associated with more aggressive cancer, associated with more aggressive disease progression. So we have begun to kind of chip away at that block of understanding what may be biologic drivers of differences in outcome by ancestry and by race. And so we have made several nice contributions to that particular research focus, and others have as well. So there are other thought leaders that have begun to try to explore this. So it's an ongoing process that we are looking at. So foundationally or fundamentally, what is it, or are there differences at the genomic level between men of African ancestry and men of other ancestries that make their disease different or more aggressive? And we have found that there are differences, and now we're trying to just understand how those differences, which are not radically different, they're not like present in every single man, how those differences may actually impact an individual patient's cancer journey. That is a work in progress, but we've begun to, I guess, fundamentally through a couple of nice publications in the last couple of years, begin to explore how the tumors may be different in terms of their genes and how their genes are activated, and how that may play a role in cancer aggressiveness for men of African ancestry. Now, we've also tried to, as I said before, think about our patients as our partners in discovery. And so, although there's a lot of potentially disappointing outcomes or prognosis for Black men or men of West African ancestry who have prostate cancer, there are also little glimmers of hope that actually maybe we can improve the outcomes for these men. And that was actually the foundational concept behind our most recent work, which we published in Nature Communications just this year in 2021. To just provide a little bit of a backstory, as we've discussed in this podcast already, men of West African ancestry or Black men do have an overall worse prognosis in terms of prostate cancer specific prognosis. And yet, there have been some reports in more advanced prostate cancers that potentially Black men actually have better outcomes in response to different therapies. And so this juxtaposition was the foundation for the most recent research that we had taken on. And more specifically, there is an immunotherapy that's approved for men who have advanced metastatic prostate cancer. And this immunotherapy, which is an FDA-approved compound, the company that sponsors this particular this immunotherapy has reported that Black men have better responses to their immunotherapy than do white men. And so that was kind of the foundation, this initial observation for us to really do a deeper dive into differences in the immune microenvironment for men with prostate cancer who are Black or men who are of African ancestry compared to white men. With that work, we've made some really interesting observations. That is that there are definitely differences in the immune microenvironment between tumors from men who are Black or from men who have ancestry, and we know that they're from West Africa. And we think that those differences in the immune microenvironment may make their tumors more susceptible to even newer, more modern immunotherapies that are out there available and coming online within the prostate cancer space.
So that's really good news and some exciting research. What you mentioned was just published in Nature Communications. So how are you going to push that forward? Are there going to be clinical trials now, sort of looking at immunotherapy-based precision medicine for these folks?
Well, that's a great question. So traditionally, immunotherapy has not been very successful for men with advanced prostate cancer. And as I mentioned, within the existing FDA-approved compounds, the company that sponsors these compounds has reported that black men have better results than white men. And when we did our analysis looking at several large cohorts of men with prostate cancer that were defined with self-identified race or were defined with their genomic ancestry, we found that actually there was enhancement of the immune microenvironment in men who are black or men of African ancestry. But more importantly, we found that overall, individuals who had enhanced immune microenvironments within their tumors, they actually had improved outcomes in terms of cancer-specific survival. And so based on that information, we're developing a prospective clinical trial for all men, and it's really not a race or ancestry-based trial, but rather it's a trial that would be based on the degree of immune activity within a tumor, kind of agnostic of self-identified race and agnostic of genomic ancestry, but rather dependent on how revved up is their immune microenvironment within the tumor. And so it's what we would call a precision medicine-based trial that we're working to develop to really explore some of these initial observations we made in our first study.
Can you tell me, what is your goal now over the next decade or so to try to close this gap, to address this health disparity with black men and prostate cancer?
Well, I think there's two main themes. One is to improve and really level the playing field in terms of access to care. And that would be, I think, would be awesome, for not just prostate cancer outcomes, but overall health outcomes, to really level the playing field and enhance access for all patients, all individuals in our city and in our state and in our country. And I think with that improved access, we'll have improved health outcomes overall. And then in a complementary fashion, if we can identify unique vulnerabilities amongst different tumors, that will also enable us to do precision medicine-based trials that can address an individual cancer's vulnerability. And in many ways, if we can really understand that for all men, then we don't really see their tumors as tumors from a black man or tumors from a white man, but rather they're just tumors agnostic of race, agnostic of ancestry, but just more like, this particular tumor is vulnerable to treatment X, and this particular tumor is vulnerable to treatment Y, based on the genomics of the individual tumor. So really being very precise, but being precise in a way that's agnostic of the ancestry or the race of the patient, and really being precise about, what makes that tumor vulnerable.
Now, that's very exciting. And it seems like with each one of these publications, we're inching closer to that reality.
It's definitely a passion of mine. And fortunately, it's a passion of many other smart individual scientists here at Northwestern and throughout the country. And as a community, I certainly hope to be able to continue to participate in this important work.
Well, before you go, I just did want to mention, you have this reputation as an outstanding clinician and surgeon, as well as a scientist, and you've had some really influential patients over the years, famous actors, musicians, even world leaders. Just tell me a little bit, have these relationships helped you at all to educate the public about prostate cancer?
Yeah, it's a great question, and thank you for bringing that up. I do think so. I think that, like I said, all my patients I really view as my partners in discovery, and I have always listened to my patients, and many patients have been very generous with their time and working in a variety of opportunities, from being an individual patient guide to help a new person navigate their new cancer diagnosis, to helping me talk about prostate cancer screening on the national news, to hosting me on a nationally syndicated radio show. So each patient, really try to engage with them and help them through their own individual journey. Many of them are really willing to give back. The way and how they give back definitely differs, but I certainly am grateful for everybody. So If you're willing to be a patient navigator for the next person who has a diagnosis, that's awesome. And to me, that's tremendous. And if you want to help talk about the disease state on the national news, well, that's awesome too. And I'll take it all.
Thank you so much, Dr. Edward Schaeffer, for joining me today, talking about your research and some of the exciting things that we can look forward to.
Well, Erin, thank you very much for having me today. I really appreciate the time, and have a great day.
You can head to feinberg.northwestern.edu to listen to past episodes of the show and claim continuing medical education credit. And also be sure to subscribe to this show on Apple Podcasts or wherever you download your podcasts so that you never miss an episode. Thanks for listening.